Good evening, everyone. Today we will have a discussion on the chest X-rays and what to look for. Considering the current situation in the world with the coronavirus and the stay-at-home model that everyone is following now. We will do this session online and we will discuss your questions and will explain them during the presentation. So, regarding the chest X-ray, first of all, what do we have to look for? We have to look for these 6 items, 6 things that we need to know about and we need to examine in every chest X-ray. These are the lung parenchyma, the pleura, the hilum, the mediastinum, the diaphragm, and the chest wall and bones, other bones. So, first of all, let's start with the lungs. The lungs usually are involved in what's called parenchymal diseases. The parenchymal diseases will cause either increased radiographic density or decreased radiographic density. Either the lung become whiter or darker. Increased radiographic density or decreased radiographic density. Regarding the increased radiographic density, the things that cause increased in the lung density, make it whiter, they are either predominantly airspace disease or predominantly interstitial disease. Now, what's the difference between the two? Regarding the lung, it's composed of interstitial tissue. This tissue, it's between the alveoli and the airspace component. That's the bronchioles and the alveoli that is connected to them. So it's the airspace part is the part that contains air, while the interstitial part is the part that contains supporting tissue, the tissue that helps the lung maintain its shape, that hold the lung in conjunction with with each other. Each part of the lung is held in its place by an interstitial lung tissue. So, regarding the airspace disease or the alveolar disease, the disease is connected or filled or is filling the alveoli, the bronchioles and the bronchi by any material. For example, pus, blood, water, protein, cellular debris, anything that fills this part, the part of the lung that contains air, it's called airspace disease. Regarding the interstitial diseases, also it is the diseases that affects the interstitial tissue, the part that keeps the lung in that supports the airspace, that supports the alveoli, keep everything in its place. Okay, so we now know the difference between airspace disease is the diseases that involves the alveoli and the air ducts, the bronchi, bronchioles that makes the air reach the alveoli, and the interstitial disease is the disease that affects the interstitial tissue, the tissue that is around the alveoli, and it does not have any role in the oxygen exchange or transfer, but it supports the lung parenchyma. Now, how do we differentiate between the two on a chest X-ray? How can we differentiate between alveolar or airspace disease and interstitial disease or changes on a chest X-ray? In the airspace disease, the diseases that make something inside the alveoli, it will appear as either called fluffy or blobby, like fluffy appearance. While in the interstitial diseases, it's mostly in form of small nodules. Usually, the airspace disease has ill-defined margins, while the interstitial pattern is usually presented as linear or reticular pattern. You see as line or as a reticular pattern. This indicates interstitial lung disease. The alveolar changes are either, if you follow it up, you see that they are coalescing or merging, uniting with each other. Everyone is uniting with the rest, okay? While the interstitial changes, they are linear, reticular with septal lines. You can see there are lines and they are not merging together. The alveolar changes are either segmental or lobar, while the interstitial changes are reticulonodular. Okay? The distribution in the alveolar, in the airspace disease, are either segmental, involve some segments of the lung, or lobar, involving a lobe or more of the lung, while the interstitial changes are more widely scattered. They are reticulonodular in appearance. Sometimes in extra findings are air bronchograms. You see it in airspace disease. We will talk about that later. While in the interstitial changes, you see evidence of reduced lung volume because the parenchyma that supports the airspace are involved. Okay, and you can see honeycomb pattern, which usually indicates an end stage disease. It's very bad lung. So till now everything is obvious. Everyone is hearing me and understanding what I'm saying?
Yes.
Okay, so
Yeah.
this is an X-ray of a child. You can see there is an opacity in the upper zone of the right lung. This opacity, this magnified view, you can see it's homogeneous. Okay, it's in a lobar distribution. This is the distribution of the right upper lung lobe. Okay, it is coalescing and merging. Okay, and it is not reticular, not reticulonodular. It's homogeneous, fluffy or bubbly appearance. It's like cotton. Okay, so this indicates that here we have an alveolar disease, an airspace disease, something that is filling the alveoli, and this alveoli does not contain air. It contains something else. Okay, in this case it was a pneumonia, and it was the alveoli were filled with pus. Okay, what about here? You have two cases or two different patterns. First, you can see here a homogeneous, white, fluffy, bubbly opacity in the right lower lung zone, and if you look carefully, you can see some air bronchograms. Okay, you can see air bronchogram here and here, and this indicates an airspace disease. It's a fluffy or bubbly or homogeneous, relatively homogeneous shadowing involving the alveoli. It's filled with pus. While on the right side, you can see there are multiple lines. Okay, in a scattered distribution, non-segmental, non-lobar, they are just lines. So this is reticular pattern, indicating, and if you look carefully, you can see some nodules, tiny nodules here, here, and here. This is a reticulonodular pattern. Okay, this indicates an interstitial lung disease. Now, one of the most common findings that we see on X-ray, on chest X-ray, is the consolidation. So, what do we mean by consolidation? When the alveolar or the airspace is filled with inflammatory exudate, this is called consolidation. So the lungs become solidated, becomes more solid, because it contains less air, more exudate, it becomes more solid. Okay, this is an airspace disease, so the interstitial tissues are intact, they are not affected, just the airspace. The airways in consolidation, the airways, the bronchi, the bronchioles, they are patent, not occluded. Only the alveoli are filled with exudate. So, how can we see that radiologically? There will be a density corresponding to the segment or the lobe that is involved. Which segment, which lobe is involved, there will be increased density. Not always, but sometimes we can see air bronchogram. Not always. Sometimes we see air bronchogram. There is no significant loss of lung volume. Here, keep it in mind, the lung volume is preserved. There is no loss of lung volume. Okay? Like for example here, you can see this X-ray, the left side is okay, it's aerated well. While on the right side there is an increased density seen almost all over the right lung, more in the middle and lower lung zones, and you can see some tiny air bronchograms here and there, and very importantly there is no volume loss, okay, and there is no reticular pattern. So this is an aerospace disease, and since there is no volume loss, it is most likely a consolidation. Now, what about the air bronchogram? What do you mean by air bronchogram? It is a sign which is defined as visualization of a bronchi within parenchymal consolidation. So you must have a consolidation in order to see a bronchogram. You cannot see a bronchogram without consolidation. Okay? So we will see how does it appear. There will be a whitish lung parenchyma, lung density. The lung will be white because it's consolidated, and within this white there will be branching lucencies. Lucency means dark, so there will be dark lines surrounded by the consolidative opacity, surrounded by the white lung. What does that indicate? If you see an air bronchogram, what does that indicate? The differential diagnosis is as following. It's either non-obstructive atelectasis, non-obstructive, there is no obstruction, okay, pneumonia, pulmonary edema, hemorrhage, bronchoalveolar cell carcinoma, and lymphoma. This is the differential diagnosis of air bronchogram. So when you see an air bronchogram, you have to keep these 6 items in mind. And what's the significance? It helps us to exclude a pleural or mediastinal lesion, because when you see an air bronchogram, this means that the abnormality is in the lung. It's not in the pleura, it's not in the mediastinum. For example here, this is a chest x-ray of a child, and you can obviously see that both lungs are whitish. They are white, not black, because they are consolidated, because the alveoli does not contain air, they contain exudate, okay? And you can see this line here, which is an endotracheal tube. It's going to the trachea, and you can see within this white lung on the right and on the left, you can see these branching dark lines, okay? These are the air bronchograms. Tamam? So till now everything is okay. Everyone is understanding what I'm saying. Is there any question? Please write in the message section. Okay, good. So now there is something called bulging fissure sign. Bulging fissure sign. What does that mean? It means when you have a consolidation, okay, we said there should be no volume loss. Consolidation means no volume loss. The volume is preserved, or the lobe might increase in size, not loss of volume, increased volume, okay? So the affected part of the lung will be bulging. This fissure, the transverse fissure, should be straight. Now, since the right upper lobe is involved, and if you look carefully, you can see some air bronchograms here and there, it is consolidated. There is no volume loss, but there is increase in the size of the lobe, resulting in the fissure being pushed more inferiorly, become convex toward the inferior aspect. Okay, this is called bulging fissure sign. So it indicates lobar consolidation where the affected portion of the lung is expanded. When you see a bulging fissure sign, this indicates most likely Klebsiella pneumonia. Klebsiella pneumonia is very characteristic with this bulging fissure sign. The first differential is Klebsiella pneumonia. Okay, other possible causes includes Streptococcus pneumonia, Pseudomonas aeruginosa, and Staphylococcus aureus pneumonia. Okay, so when you see bulging fissure sign, first thing you look for is the Klebsiella pneumonia. Other possible differentials include Streptococcus, Pseudomonas, and Staphylococcus pneumonia. تمام؟ واضح؟
Yes.
Good. Now, we will talk a little bit about the silhouette sign. Silhouette, what do we mean by silhouette? Silhouette in Arabic, it is the shadow, خيال الشيء, هو the silhouette of anything. So the rule here says, we have a rule, a قاعدة, that says if any two objects of the same density, okay, are in contact with each other, two objects of the same density in contact with each other, okay, you cannot see the border between them. The border between the two objects, you will not be able to see it. If they are not in contact with each other, you will be able to see the border between them. Okay? So, an intrathoracic radio opacity, if in anatomic contact with a border of the heart, of the aorta, or the diaphragm, you will not be able to see the heart or the aorta or the diaphragm, because this border will be obscured. It will be silhouetted. An intrathoracic lesion that is not anatomically contiguous or in contact with a border or a normal structure will not obliterate that border. يعني you will be able to see the border between the two structures. For example, in this chest x-ray, you can see that there is a fluffy, bubbly, homogeneous opacity in the right lower lung zone. In the lower lung zone, we have two lobes on the right side. We have two lobes, the middle lobe anteriorly and the lower lobe posteriorly. We know that. In the right hemithorax, in the lower lung zone, we have two lobes, the middle lung lobe anteriorly and the lower lung lobe posteriorly. So this opacity, is it in the middle or in the lower? We cannot know unless we use the silhouette sign. If you look carefully, the right heart border is silhouetted, is obliterated. It is not sharp like the left heart border. It is ill-defined. Why? Because the opacity, the consolidated part, is in contact with the right heart border, while the diaphragm is very sharply defined. It's well defined. So this indicates that this opacity is in contact with the right heart border, not with the diaphragm. So this is a consolidation of what?
Anterior, middle lobe.
Middle lobe.
Come on, right?
Middle lobe.
Okay, this is a right middle lung lobe consolidation. If we see the diaphragm and not see the right side of the if we see the diaphragm and not the right side of the heart, this indicates a right middle lobe pneumonia. While if we see the diaphragm and if we don't see the diaphragm, if the diaphragm is silhouetted and the right heart border it's well defined, this indicates a lower lobe pneumonia. So using the silhouette sign, we were able to say this consolidation is in the middle lobe or in the lower lobe. If the right heart is silhouetted, this is in the middle lobe. If the diaphragm is silhouetted, this is in the lower lobe. Okay? So, to review the parts of the chest that can be silhouetted and we can see them. What are they? First, we have this heart and great vessels image. You can see the aortic arch, the pulmonary artery, the left ventricle, the right ventricle, the right atrium, the SVC or the ascending aorta on the right side. So, this is what you should memorize, what you should know. If the SVC or the ascending aorta is silhouetted, the most likely part that is involved is the anterior segment of the right upper lung lobe. If this is silhouetted, the anterior segment of the right upper lung lobe is involved. Okay? If the right atrium is silhouetted, this is the medial segment of the right middle lobe, because the right middle lobe has two segments, the medial segment here and the lateral segment here. The medial segment is silhouetted, is involved. If the aortic arch is silhouetted, then there is an apical posterior segment left upper lobe. If this is silhouetted, then the apical posterior segment of the left upper lung lobe is involved, is consolidated, it's abnormal. Okay? What about the pulmonary artery? It is the same as the aortic arch, the same part, the upper lung lobe segments are involved. The left ventricle, it's involved in the inferior segment of the lingular consolidation. The inferior segment of the lingular consolidation, because we know that the lingula has two segments, superior segment and inferior segment. So the inferior segment is usually silhouetting the left ventricle. The right hemidiaphragm is involved in the right lower lobe consolidation, while the left hemidiaphragm and the descending aorta, you can see here the descending aorta, are silhouetted in the left lower lobe consolidation. So every one of these anatomical landmarks has a corresponding part of the lung that, if involved, it will be silhouetted. Okay? Now, how can we use this silhouette sign? Let's see other examples. For example, here you can see there is an airspace opacification or a consolidation in the right middle and mostly middle lung zone. Okay, and in which lobe is that? You can see the heart border is silhouetted, so this indicates a right middle lung lobe pneumonia or consolidation. And you can see obviously this is the transverse fissure that separates the right upper lung lobe from the right middle lung lobe. The transverse fissure is obvious here. To confirm that, a lateral chest x-ray will show you that this is the middle lung lobe. Okay, this is the middle lung lobe. Now, let's look here for this chest x-ray. You can see the chest x-ray here. What is the abnormal part? What is the involved part? Compare the the right hemidiaphragm with the left hemidiaphragm. The right hemidiaphragm looks sharp and well defined, while the left hemidiaphragm looks silhouetted, looks abnormal. Okay, so if you look carefully, this silhouetting is due to increased density in the left lower lung zone, okay, indicating a left lower lobe pneumonia. If you look to the cardiac border, it is well defined. Why? Because it is in the lower lobe, not in the upper lobe. The diaphragm is silhouetted, the left heart border is not silhouetted. Okay, So here we could easily say there is a left lower lobe consolidation. After treatment, the chest X-ray was repeated, and you can obviously see that the left hemidiaphragm is very nice and obvious, and it's sharp just as the right one. So this is before treatment and after treatment. Okay, so sorry, this is not pleural effusion. This is a silhouetting of the left hemidiaphragm, indicating left lower lobe pneumonia. However, I think the most common pathology that may cause silhouetting of both the left heart border or the heart border, whether it's left or right, silhouetting of both heart border and diaphragm. If something is silhouetting the left heart border and the left diaphragm, this indicates that we have pleural effusion. Pleural effusion will be in contact with the heart border and with the diaphragm. So both of them will be silhouetted. Okay?
Okay.
Now, let's look at this image. So it's known, this silhouette sign is not only seen in pneumonia or not only in consolidation. Any two objects of the same density can silhouette each other. For example, you can see this chest X-ray of a middle-aged patient. He has a chronic cough. Sorry. You can see there is an ill-defined left dome of the diaphragm shadow here that is silhouetting the left dome of the diaphragm, at least the medial aspect of the left dome of the diaphragm. Okay, whereas there is it's not silhouetting the heart. You can see the heart border at the arrows. It is well visualized. Okay, so obviously there is something here. There is a mass here. However, where is this mass? Is it in the upper lung lobe or in the lower lung lobe? Since it's not silhouetting the left heart border, it's silhouetting only the diaphragm, then of course this will be in the left lower lung lobe, not in the left upper, only in the lower lung lobe. Okay, and this was a bronchial carcinoma. So we can identify the location of this mass according to the silhouette sign. One of our colleagues has commented also the intermediate bronchus pathology will also can affect the right middle and lower lung lobes. If there is bronchus intermedius pathology, it will affect both the middle and lower lung zones. So if we have lung lobes, sorry. So if we have silhouetting of the right heart border and the right hemidiaphragm, also intermediate bronchus pathology should be considered in addition to pleural effusion. Now, another example of the silhouette sign. You can see this pathology here. There is something of soft tissue density bulging from the right side of the heart. Okay, you can see the right hemidiaphragm is intact. Okay, it's sharply defined. So this lesion is related to the right side of the heart, and it's not related to the diaphragm. Okay, you cannot see the right heart border. It's silhouetted. So this lesion is in direct contact with the right heart border, while it's not in contact with the right hemidiaphragm. So this indicates that the lesion is not in the lower lobe. It is most likely in the middle lobe. And here, after CT scan and further imaging, it was a pericardial cyst. It's a benign lesion, but it's a cyst, not consolidation, not pneumonia. So it's the silhouette sign is not only means pneumonia. There are other things also that can cause silhouette sign. Some pitfalls that we should be careful about. In a small percentage of normal individuals, the right heart border may not be seen. The right heart border, they are normal, nothing wrong with them, but the right heart normal is not obvious. Okay, if there is a depressed sternum, okay, pectus excavatum, they call it pectus excavatum, depressed sternum, it will produce loss of the right heart border. This appearance will mimic middle lobe pneumonia because the depressed sternum will push the heart posteriorly and to the left, so you will not be able to see the right heart border. The heart is pushed more posterior and more to the left, and also there will be bunching of the soft tissues of the deformed chest wall, causes some increase in the density. The chest wall is abnormal, it's deformed. These soft tissues will be collapsed together, condensed together, causes a slight increase in the density. For example, you can see here, is there any right heart border? No, there is no right heart border. I cannot see the right heart border, okay? So this was a pectus excavatum. The sternum is depressed, pushing the heart to the left side. It is not a pneumonia. There is some increased density here, not due to pneumonia, it's due to the condensation of the soft tissues. Another pitfall you can see here, there is some increased density here and silhouetting the right heart border. So is this a right middle lobe pneumonia? No, it's not. In this case, it was an epicardial or paracardial fat. This is not a pneumonia, it's a fat pad here that causes some increased density and it's silhouetting the right heart border. So the history, the direct inspection, physical examination can be important and might solve a problem. You need to see the patient and you need to take some history, okay? Again, the borders here, some say it's a well-defined border, but in cases of consolidation, the transverse fissure will also be well-defined border. So I don't think this is something that we can differentiate or help us to differentiate. Regarding the previous chest x-ray, one of our colleagues has commented that something that helps us to know that this is not in the lung, it's in contact with the right heart border, but it's not in the lung, is due to the angle here. You can see the angle here is acute, it's not obtuse, so this is not in the lung, it's in contact with the right heart border. While if the angle was obtuse, like wide angle, indicates this sorry, I think I got it on the reverse. If the angle is wide, it's obtuse, then this indicates that what the lesion is in the lung. While if the angle is acute, this so the lesion is outside the lung. Sorry, I'm so sorry. While the if the angle is acute like this, okay, it's in the lung. If this lesion is in the lung, the angle will be acute. While if the angle is wide, the lesion is outside the lung. Good. I'm sorry, some disorientation. No problem. So let's continue. So it's not only the presence of silhouette sign that's helpful, but the absence of silhouette sign also is helpful. Can tell us where is the shadow. Is it a consolidation or a mass? Okay, the consolidation or the mass, where is it located? At least we can know where it is not located. For example, this is a diagram that shows a mass or a consolidation or an opacity, whatever you like, on the left side, okay, and here the left heart border is not silhouetted, so it's the absence of the silhouette sign, okay, that help us to know where is the lesion. This lesion is not in the lingula. If it was in the lingula, it will silhouette the heart. It's not in the lingula, it is in the lower lobe. So the absence of silhouette also is helpful. Again, this is another example. You can see that the right heart border This is a mass or consolidation or an opacity, whatever you like, call it. This lesion is in the right lower lung zone. It's not silhouetting the right heart border. So it is not in contact with the right heart border. So it is not in the right middle lung lobe. It is in the right lower lung lobe. Okay? So the presence of silhouette sign can help us decide where is the lesion, and the absence of silhouette sign also can help us decide where is the lesion. Tamam? For example, let's see this case. There is an opacity, almost homogeneous, little bit heterogeneous, seen in the right middle lung zone that is silhouetting the right heart border. I cannot see the right heart border. Why is that? Because this opacity is silhouetting it because it is in contact with the right heart border, indicating that this lesion is in what lobe of the lung? This is in the right middle lung lobe because it's in contact with the right side of the heart. And you can see the transverse fissure here, very obvious, and you can see the oblique fissure here, also obvious, separating the middle lung lobe from the lower lung lobe, and the transverse fissure separating the right middle lung lobe from the right upper lung lobe. Okay? And on the lateral chest x-ray, you can see this is the middle lung lobe, opacified here to confirm that this is consolidation. There is some, of course, here an evidence of COPD, the obstructive pulmonary disease, due to the hyperexpansion of the lung, and you can see the reticular pattern here indicating airspace opacification on a background of interstitial lung disease. Now, what about collapse? What's the difference between consolidation and collapse? Answer is easy. Collapse is loss of volume, while consolidation, there is no loss of volume. When there is loss of volume, there is a collapse. Okay? When there is a collapse, it means the airways, the bronchioles and the bronchi are also involved. In the consolidation, the alveoli are involved, as we said, the alveoli involved, but the bronchiole and the bronchi are not involved. That's why it stays the same volume. When the bronchi and the bronchioles and the airways are involved, then there will be volume loss, indicating that there is a collapse. So when you say a collapse, it means something that lost volume, or now it's smaller in size. While in consolidation in general, as we said, it is preserved lung volume, sometimes increased lung volume, bulging fissure sign that most likely is due to Klebsiella pneumonia, as we said earlier. So, collapse are of two types. It's either passive collapse or active collapse. Passive collapse means something from outside the lung compressing on the lung, making it lose volume, becomes smaller. While active collapse is due to involvement of the airways, causing no air to reach the airways, leading to loss of volume and collapse. So if it is passive collapse, it is due to compression from outside, while active collapse is due to volume loss because the airways are involved. So sometimes collapse can be due to fibrosis. Okay, not the airways are not involved, but there is a fibrosis causing loss of lung volume. For example, the active or obstructive or resorptive collapse, the collapse that due to airway obstruction, can be caused by a tumor, a mucus plug, a foreign body that causes the airway to block, to close, leading to no air in these airways, leading to loss of volume of the parts of the lung that is fed by these airways or these bronchioles. This is obstructive or active collapse. While compressive or passive or relaxation collapse is due to compression from outside by something like a pleural fluid, for example, pneumothorax, adjacent intrapulmonary space occupying lesion compressing the adjacent parts of the lung, causing loss of volume. For example, here you can see this is a pleural effusion compressing on the lung, leading to loss of volume. So this is a passive collapse. The cicatricial or the fibrotic collapse is when the interstitial part of the lung becomes so fibrotic that it loses volume, it shrinks due to the fibrosis. Usually this can be seen in patients of all TB infection after radiotherapy, that's radiation fibrosis, secondary to radiation pneumonitis, also in pulmonary fibrosis in general, and that has many causes. So, what are the signs of collapse? The signs of lobar or pulmonary collapse. They are either direct signs or indirect signs, either direct or indirect. For example, the direct signs are opacity of the affected lobe or lobes, crowding of the vessels and the bronchi within the collapsed area. The part that is collapsed, you see the vessels and the bronchi are crowded, they are more numerous because there is volume loss leading to these vessels and the bronchi become closer to each other. Also, displacement or bowing of the fissure, opposite to the bulging. The fissure will be عكس bulging fissure, there will be bowing of the fissure. Okay. Indirect signs of collapse are compensatory hyperinflation of the normal lung. You see the normal lung, the one that is not involved by the collapse, becomes hyperinflated, increased in size. Also, displacement of the mediastinal structures toward the affected side because there is loss of volume, so the body does not like to keep anything empty. Everything has to be full. So if the left lung is collapsed, lost volume, the left the things in the middle like the mediastinum will be displaced to the left to fill the space. Also the hilum will be displaced to where the abnormality is. Yani the left hilum will be displaced to the left side more, the mediastinum will be displaced to the left side if there is a left side collapse. If there is a right side collapse, there will be the opposite things. Also, elevation of the ipsilateral hemidiaphragm. If the left side is abnormal, the left hemidiaphragm will be higher. If the right lung is collapsed, the right hemidiaphragm will be higher, and there will be crowding of the ribs on the affected side. The ribs will be more close to each other. For example, in this case, you can see there is a left lung collapse. The left lung is not seen, it's not aerated, it's very dense. You can see the mediastinum, the heart and the great vessels, the trachea, even the right and left main bronchi are all displaced to the left side. You can see there is compensatory hyperinflation of the right lung. This right lung is crossing the midline, and this is the border of the right lung. There is compensatory hyperinflation of the right lung, and you can see that most likely the left hemidiaphragm is somewhere here because there is compensatory elevation of the left hemidiaphragm. Okay, and you can see the ribs here are crowded, they are very close to each other compared to the other side. Okay, so all of these are direct and indirect signs of volume loss. Again, there is another sign that is seen in cases of collapse, that's called the golden S sign. The golden S sign is seen in cases of collapse due to a hilar mass, most commonly on the right side. The right hilar mass will cause occlusion of the right upper lobe bronchus, and this will result in collapse and volume loss of the right upper lung lobe. This right upper lung lobe will become like this, will show, this is the transverse fissure, appears like this, like an S, inverted S. That's what's called convex S sign. because the mass gives the convexity to the without the mass, the fissure will be like that, will be convex to the upward, but the mass will give it a convexity downward, so making it the S shape. Now, the last thing we will discuss today is the differences between collapse and consolidation. In collapse, there is volume loss, while in consolidation, there is normal or increased volume, as we said. In cases of increased volume, this indicates Klebsiella pneumonia or some other less common etiologies. There will be, in collapse, there will be associated ipsilateral shift of the mediastinal structures, while there is no shift in consolidation. If shift is present, it can be to the contralateral side, not on the ipsilateral. Okay, the collapse presents as a linear or wedge-shaped opacity, that is the lobe that lost volume becomes in form of linear or wedge shape, while in consolidation there is the lobe maintain its shape. Okay, in collapse the apex of the linear or the wedge shaped opacity becomes at the hilum, and we don't see air bronchograms in collapse. But sometimes air bronchograms, not always, sometimes seen in consolidation, and consolidation it's not centered at the hilum. It's above all the lobe. The lobe keeps its shape, or the segment keep its shape, no signs of volume loss. Okay, so the opacity is not centered at the hilum. What if we have signs of volume loss and we have bronchograms? We said bronchograms is seen in consolidation, while volume loss indicating collapse. So what if we see air bronchogram with signs of collapse? This is what we called collapse consolidation. It means that the process started, the pathology started with consolidation and is progressing to collapse. يعني some parts of the lungs, some segments of the involved lung lobe is collapsed, and some of them are consolidated and beginning to collapse. So if we see air bronchograms plus signs of collapse like volume loss, for example, this indicates we have a consolidation collapse. The process started as consolidation and now it's progressing to collapse. For example, we have a tumor that occludes the bronchus, and this tumor partially increased in size, causing slightly increased in the narrowing of the bronchus over time, making collapse at the consolidation at the beginning and later collapse. I think we can stop here now, and we will continue in the next session. Thank you all for listening. Wish you a very happy and safe time.